Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Let's do this, Dr. Lamberg. I just have a funny thought. As that first video comes on, I just want to say I'm a little bit of a fake because that picture on the screen of me, I was actually mid-MARPE. Back then, it was just the MSc. And I had a huge diastema. And we happened to be taking office photos that day. And I was like, oh, no. So the photographer filled it in with white. So the other day, I was like, I should see what that looked like. So I had him send me the original. I should swap it for the original, don't you think? It's like, I don't know, 8mm gap. It's pretty funny. Yep. So I'm looking at that photo now, totally laughing. But anyways, welcome. Yeah. Welcome back, Dr. Lamberg. So we are here for a part 2. Our last podcast episode was amazing, and we went over and you talked in detail about anatomical factors, but also stressing the non-anatomical factors of sleep disordered breathing. If you want to check Dr. Lamberg's bio, just go back and listen to the last episode. He's a restorative dentist with specialty in dental sleep medicine, has invented oral appliances, written textbooks, lectures all over. Dr. Lamberg is amazing. Welcome back again. Thank you so much for being here.
Thank you. Thank you for having me.
Your time is so valuable. So I really thank you. And I know you spent time putting together a special presentation for us. This is a special one called, we're calling it Airway Buffet 2, because our first interview, right, we were saying this is Airway Buffet. So when we're treating airway issues, there's so many things that we can pick from and little pieces to assess and treat in so many details, and it differs for each patient. So we're going to look today at a presentation Dr. Lamberg created for us called, we'll call it Airway Buffet 2, Ingredients for Airway Collapse and Airway Resistance, talking specifically about these non-anatomical factors. Is there anything I'm missing from that title or anything, Dr. Lamberg? Anything you want to say before we get in to it?
No. Let's do it. Let's get it going.
Let's do this. Take it away, Dr. Lamberg.
So thank you, Nicole. It was really great last time. I actually watched the whole video myself, and I really liked it. We covered a lot of ground, and you had seemed to be pushing me the whole time to do the non-anatomical things, and I didn't have my slides, focusing on that per se. So I thought, and we talked afterwards, that maybe we just make one brief 35, 40-minute piece just on the non-anatomical ones. And since the Airway Buffet, we just started joking around and we called it the Airway Buffet because there are so many treatment options. So this is Airway Buffet 2. And it's just all the ingredients. What are the pieces of this puzzle? Where do they come from? How do they interact with each other? And when should you intervene? And then why should we have prevention? Because we all know the answers to some of these questions, but we're going to run through that in this presentation. As we had in the previous presentation, Airway Buffet 1, we had data collection. And I think data collection is really the main hub, and all the spokes go out from the data collection. Now, from the data collection, which you probably all have the form, I think Nicole made that available to you. And if not, you can email me and I'll send you a copy of that colored form on your upper right. From the data collection, we actually find out that there are 7 targets that we're going to focus on: nasal resistance, soft tissue restrictions, skeletal and dental compensations, physiologic non-anatomic compensations. This is number 4 on the 7 targets. Now, to be fair, Nicole, we should really have 7 presentations because each one of these has a whole half-hour, 40-minute presentation that goes with it. I haven't drawn them up yet physically, so we don't have slides for them yet. So today, just to put this in context, we're going to be working on number 4, the physiologic or non-anatomic compensations. And if you look at your data collection sheet on the right here, you'll see structure, function, and behavior. So the functional part, this is the functional part, number 4. This is the physiologic, non-anatomic.
Dr. Lamberg, can I interrupt?
Sure, anytime.
Okay, so those 7 targets, that is wonderful. And we may need to have you, we may just have created more work for you because you might have to come back 6 more times to hit on each target. That's all I wanted to say, but this is
All
great.
right.
Thank you.
Yeah, I think we'll talk about that after the show. Okay. So just let's zoom out. Everybody zoom out. All right. Put the zoom out hat on. Airway collapse or increased resistance. All right. So you don't need to have the full collapse. We're really concerned about the sympathetics being upregulated. So increased resistance will have the same effect on the nervous system as the airway collapse in many cases. Now, if you go to that first piece here, you'll see I have anatomic and non-anatomic problems. There's both. Today, it's going to be the non-anatomic problems. And now from there, we go down to airway collapse or increased resistance. So they both contribute to that. Why? Because they upregulate your sympathetic system. What happens when you upregulate your fight or flight part of your nervous system is you have chronic inflammation and mitochondrial dysfunction. Two things, and they're different. Now, the inflammation releases cytokines and a lot of oxidative stress, and it actually damages the mitochondrial DNA. And then there's a lot of reactive oxygen species that are released from the mitochondrial dysfunction. And that's what we call oxidants and oxidation. And frankly, everybody that's watching this, you like to have antioxidants in your diet and have a lot of those. And that's because there are these free radicals, oxygen radicals, mitochondria produce when they fumble, so to speak. Along the electron transport chain, they fumble the electrons. And at the end, it's like everybody's at the terminal and their planes aren't taking off and there's a big long line. So people get all pissed off. And that's what happens to the electrons, and that's what causes the free radicals. Now, this leads to tissue injury, metabolic imbalances, and this is what is underneath all of the non-communicable diseases. NCDs. We're going to use that word, that abbreviation a little bit, that acronym. So again, so we're still zoomed out now, okay? And we're going to divide this in half. 𝐃𝐈𝐒𝐂𝐋𝐀, which is the anatomic stuff, and that's the critical closing pressure. It's the measure in the context of obstructive sleep apnea. It assesses the collapsibility of your upper airway. How easy does this tube collapse? And that's measurable. That's measurable. To truly measure this, you need an esophageal pressure gauge to put down. And nobody really does that except for one guy in Texas. And this is a problem. However, there are algorithms. In other words, they can take your PSG and the data from your PSG, and they can actually derive the 𝐃𝐈𝐒𝐿. And I'll explain later why we want to know what is your critical closing pressure. You want to have the tube collapse at a very negative pressure, because when you inhale, and especially at end expiration, there's a very low pressure. And when that's a very low pressure, you don't want there to be resistance and collapse. You want a really strong, fat, big airway there. All right. Now, this is the 𝐃𝐈𝐒𝐿 versus the non-anatomics. I call these the non-anatomic triads because there are primarily three. So going down here and explaining the 𝐃𝐈𝐒𝐿, the lower, meaning the more negative the 𝐃𝐈𝐒𝐿, the less collapsible the airway. The higher the 𝐃𝐈𝐒𝐿, closer to zero, that means that it's more collapsible. And there's healthy pharyngeal airway has a 𝐃𝐈𝐒𝐿 between -10 and -15.
How do we know -10 and 15? Do you know where they came up with those numbers as being healthy?
Yes, you're looking at it in this slide. So
Okay.
this was done by Danny Eckert. And what he showed here was the AHI along the top. And look at they have apnea-hypopnea index of 40. If they're severe with their apnea-hypopnea index, look at where their 𝐃𝐈𝐒𝐿 is. It's positive, +5 centimeters of water. Okay. And if they have 0 apneas and hypopneas, look where their 𝐃𝐈𝐿 is. It's down here, -15, -10. And frequently we'll get a CPAP patient that comes in and we see that they were given 12 centimeters of water pressure. That's really like sticking your head out the window going 30, 40 miles an hour. It's not so easy to get used to that. So that's why a lot of the people can't continue to use the CPAP machines, because when they go to the sleep lab, the technicians keep turning it up to eradicate or to mitigate the collapse of the airway, and they don't pay any attention to such a high pressure. That's also why on the Lamberg questionnaire, if you have a previous trial with the CPAP and you were using over 10 centimeters of water pressure to offset your positive 𝐃𝐈𝐒𝐂𝐋𝐀, it's unlikely that just the oral appliance will work. So that's one of the questions we ask on the Lamberg questionnaire. Does that make sense?
I'm sorry to keep throwing in questions. It's just really interesting to me. So hopefully it's not throwing off the flow of this beautiful presentation, but I have a
No.
𝐃𝐈𝐒𝐂𝐋𝐀 question. It's looking at how collapsible the airway is. Is that only when there's a full collapse as in an apnea? So what
No.
about someone who has UARS? Is it looking at the brain arousal?
Yeah, that's why I wrote collapse or increased resistance.
Okay.
So,
But
and
it's
it's
correlating that narrowing of the airway with the EEG. And when that
correct.
triggers brain arousal, that's when we're calling that a collapse.
It's a collapse. It can be a partial collapse. It can be a full collapse.
Okay.
And if they do a DICE, they can actually decide, or they can determine if it's a circumferential collapse, if it's an anterior-posterior collapse. And there are certain protocols for determining whether or not some of these procedures, like the Inspire, might or might not be usable. If you have an AP collapse, yes, then you can use the Inspire. If you have lateral wall collapse or circumferential collapse, no, that's not good. So it could be a partial collapse or a full collapse. We're just talking in general terms here. I just want people to understand that one of the keys to the whole airway education program people should really appreciate is that there's an air tube, and it's collapsible. At some negative pressure, it's going to collapse. But for everyday usage and sleeping, -10 to -15, your airway should withstand that without going crazy, without collapsing, without having a sympathetics turned on, because the pressures will drop into that range at certain times, and you want an uncollapsible airway. Now, what is the non-anatomic triad? These are the physiologic contributors that add to the collapse of the airway. Arousal threshold is one, loop gain is the other, and muscle recruitment is the other. Now, there are other non-airway issues that we're going to we'll talk about at the very end of this presentation, but these are the three big ones. So the arousal threshold is defined as the amount of stimulus required to cause an arousal. And it doesn't change the neuromuscular properties of the airway. It causes a little perturbation in the airway, will cause you to have it's a neurologic response, and you'll have an arousal, which is not necessarily waking up, but it's having an EEG arousal. The loop gain is a little different. Loop gain is defined as the sensitivity and stability of the respiratory control system's response to changes in ventilation. Does not modify the physical, anatomical, or neuromuscular properties of the airway. So it doesn't change the 𝐃𝐈𝐒𝐂𝐋𝐀. However, the loop gain may increase the apnea events, and we're going to discuss how that could happen. So these things don't change the 𝐃𝐈𝐒𝐿, but they actually cause more apneas or more fragmentation in sleep in general. Then there's the muscle recruitment, and this modifies the 𝐃𝐈𝐒𝐿. Now, muscle recruitment could be a neurologic problem. It could be a muscle problem. So muscle recruitment is a general term, but it does affect the collapsibility of the airway. And we're going to talk about where that comes from, what causes it, and what we can do about it. Now, for the people that like pictures, this
Could I ask
shows.
something about muscle recruitment when we're doing
Yes.
myofunctional therapy? Is that what we're targeting? Is the muscle recruitment aspect?
Not necessarily, but partially. The answer to the question is, I don't think you're having an effect on the neuro part of it, but the muscular, you're building the muscles and making them stronger. But what happens if someone's had apnea for a long time, they may just have a fibrosis of some of the muscle fibers, all right? They may have uncoordinated muscle fibers. So you might be helping the coordination of the firing of the muscles, but there's also a neurologic component which actually turns the muscles on. So I'm not sure if the myo or the SLP is going to help that. So you're going to, yes, to part of it, but not all of it. You'll have an influence on. So the airway size is resistance and collapsibility of the upper airway. This is from LV, Live. And anyway, it shows a couple of things here, which is just the physiologic pieces of this puzzle. For instance, here's the soft tissue, and this would increase resistance. You have fluid accumulation, rostral fluid flow, like when you lie down at night, the fluid will go up to your neck, and someone, or if you're pregnant, airway mucosal edema. These are morphological abnormalities. Now, on the other side, we have low arousal threshold. If you look where this This goes to the brain, to the cortex. And so what's going on here is you're having a very little change in the airway pressures, and bang, it's kind of turning on your nervous system. You're having an arousal. At sleep onset and in REM, you're having a decrease in chemosensitivity. These are the receptors. You also have central respiratory neurons, and they decrease your ventilatory drive. Upper airway dilator muscle activity goes down. So there's anatomical predisposition to airway pressure. There's passive and active 𝐃𝐈𝐒𝐂𝐋𝐀. Passive is when the muscles are suppressed, and active 𝐃𝐈𝐒𝐂𝐋𝐀 is when the muscles are responding. So this is an example. Loop gain, unstable respiratory control. Think of loop gain as stopping breathing, and your carbon dioxide builds up, and then you're blowing off all the carbon dioxide. And after that, carbon dioxide is the respiratory driver. So that stimulates respiration. So if you blow it off, you might have a central apnea, and the oxygen levels will build up, but you need carbon dioxide to get the oxygen off the hemoglobin also. So your body makes an attempt to prevent that, but you might just be hyperventilating, getting rid of all the carbon dioxide. After that, your breathing may stop, and then you start over breathing. So it's very unstable, it goes back and forth, and that can increase the arousals that you have. So this is just a introduction. This is a PDF, by the way. I think everybody has seen this. This is Top Gun, and he calls it this goose. This is what I call a target-rich environment, and it's a famous line. And unfortunately, the movie clip won't play because we're in PDF mode right now. And we do have a target-rich environment, and that's why I put this in there. And again, we're still zoomed out, but this is just to give it context to exactly what I'm talking about. You have the pathophysiology of OSA. What causes the increased resistance or the collapsibility? Well, we know about the anatomic, and then we have the non-anatomic. This is the myo stuff and the SLP stuff, the behavioral stuff. And in fact, if you look, that splits up to habits that the patients have and muscle function. So these are right in the wheelhouse for the myofunctional therapists and also for the speech and language pathologists. But over here is the physiologic stuff. And this is what we call function. This is, how does that air tube function? What is the loop gain? What is the arousal threshold? And what is the muscle recruitment? So we are talking now about non-anatomic, physiologic. And we're going to go now just briefly to the anatomic.
A question about the non-anatomic, the three factors you talked about: arousal threshold, loop gain, and muscle recruitment. And you had said in the last lecture that people that would say have 1/3 of each of those, or how do you describe that?
Well, what they found, what Eckert found and Wellman, they did a lot of work together, was that everybody has some degree of anatomical compromise. And about 1/3 of the patients that they were examining had each of those non-anatomic physiologic problems.
Okay.
So,
and do people have all three of those factors, all three of those non-anatomic physiologic factors, or is it usually just one?
the way they described it in their study is they usually have one, but could they have more than one? Absolutely, 100%. They didn't do studies on people with all of those problems, but they looked demographically. There was a kind of a demographic peek at everything, and they found out 1/3 of the time it would be patients would have loop gain, 1/3 of the time they would have a muscle recruitment problem, 1/3 of the time they would have arousal threshold. So whether they had the other two, I don't know.
Okay. I would just think, because having sleep disorder breathing really changes that whole autonomic nervous system, the functioning of the muscles, especially if they're snoring, we're going to actually damage the tissues, that I would think most people who've had sleep disorder breathing for years will have all three of those. Some combination where they're hyperventilating, they're also waking up quickly, especially the UARS, and they're having some muscle recruitment issues because they're also having the neurological piece. So I would just think, wow, people would have all three, not just one. But
yeah, for sure, the muscles can be actually damaged. They can be traumatized by all the starting and stopping of breathing and overworking and fibrosis and lots of problems. And there could be blood supply that's compromised to the area as well, and their nerves might not work to the muscles. So this, 100%. So the goal of our treatment, when you have this collapsibility of the airway, has to be to allow the critical closing pressure to go down. okay, to a larger negative. And when we talk about atmospheric pressure, atmospheric pressure is measured in millimeters of mercury or centimeters of water. So 1 atmosphere is 1,033 centimeters of water. So I'm glad you know that. You can pass your board test question. But let's talk about this in terms of centimeters of water. That's the common way that it's talked about, especially with CPAP. They always talk about the pressure of the CPAP machine and the collapse of the airway. So at atmospheric pressure, that's where we are right now, it's 0 centimeters of water. That's the pressure. That's in centimeters of water. It's called 0 centimeters of water. Now, apneics, like I showed in the graph before with all the little balls on it, apneics have a critical closing pressure above 0. Hypopneas, if someone just has a lot of hypopneas, it might be from 0 to -4. People that snore might have a collapse of that airway from -4 to -6. UARS, it's estimated -2 to -6. So anytime you have a critical closing pressure that's greater than -5, and again, I'm going to say that would be -4 or -3 or -2 or 0. That's greater, more positive. You have an anatomically compromised airway. So normals are -8 to -10 and even over -10. And that's what we want. So as the peak rate increases above -8, in the positive direction, airway pressures fall below the critical closing pressure, and that's what causes the collapse. Okay, so if you have -8, but your tube drops down to -10, then the tube just had a negative pressure and that went more negative than your peak rate. So then it collapses. If your mouth is open to close, that decreases the critical closing pressure by 4 centimeters of water. Now, that's why mouth tape is such a big deal and everybody talks about it. And recently I've heard some ENTs mention that they don't like mouth tape. So, I have another take on it. I don't use mouth tape in my office ongoing. I tell them they're training wheels. When I give mouth tape out, I say, wear this for a week to 2 weeks. And I consider it to be strictly for changing the behavioral pattern of their mode of breathing. I don't consider it to be a long-term solution. And I think that's misunderstood by some of the physicians out there, and that's why they have opposed it. But it's really good at doing behavioral changes just for a week or 2. Also, there's another thing, 10% weight loss, and that's amazing. That equates to approximately 30% decrease in your apnea-hypopnea index, okay? Now, as far as peak rate goes, it changes your peak rate 2 to 4 centimeters of water. Okay, so that's really important to understand and appreciate that weight loss changes your critical closing pressure. So the airway is a lot better at staying open. It slows down the air. If the air tube is bigger, everything is going to be slower and it's going to be less collapsible. Now, why do we need this peak rate data? We need it because we're going to add up all the different therapies that we can provide, and we hope to get them to -10 or -12 and not have their airway collapse. And we can't always do that with a piece of plastic, an oral appliance, for instance. So the higher your peak rate, more positive, that means it's more collapsible. So understand, appreciate that. Now, the oral appliance, where does that fit in? Well, that changes your critical closing pressure by pulling your tongue forward out of the airway. It changes it about 6 centimeters of water. So if you want to go to -10 or -12 and you're already at -4, are you going to, it's kind of hit or miss. Are you going to make it? I don't know. Maybe. Sometimes it'll work, sometimes it won't. But you could combine it with other forms of therapy. You could give them sleep hygiene tips. Side sleeping is going to make a difference. Mouth breathing is going to make a big difference if you can change them to nasal breathing. If you can get them to lose weight, that's another thing. So everything together, if you throw it all in the blender, hopefully you'll get them to -10 or -12 critical closing pressure. So this is the anatomic part, right? We're setting the table here, and then we're going to talk about the others. Here's the physiologic or the functional part. Now, there are the 3 parts here. And again, A, B, and C, arousal threshold, loop gain, and muscle responsiveness. And then the 3rd part is behavior. Now, this is different. This is for the myofunctional therapists, and this is for the SLPs. And I broke non-anatomic or behavioral thing into 2 separate functions, because if you look at this, they're going to be operational in your therapy sessions differently. You're not going to approach habits and muscle function the same way. Habits are habits. You got to break their habits, and that takes a certain kind of work. And if they have problems with their muscles, you have to work those muscles and give them exercises for those muscles. And some of those things are very difficult to change, but habits and muscle function, they might be related, but they're different. And breathing behavior, tongue posture habit, mouth and nasal breathing habits, sleep position. So again, some of them are habits and some of them is muscle function. So now we're going to 2. That's what the seminar today is all about. It's about the physiologic, and we're going to take a deeper dive and we're going to look at this. This shows a compromised anatomic airway over here. We have a narrow, crowded, collapsible upper airway. And here is the arousal threshold. Now, we don't want this patient to have an arousal. Here's the EEG, so here's the arousal. We don't want them to have an arousal at this pressure drop, epiglottic pressure. We want them to be able to go down here. But if they have an arousal here, they're going to have the EEG response over here. So this just shows what's going on, what the arousal threshold does. It has an impact on the EEG. Now, if you have loop gain and unstable ventilatory response, you have a certain required breathing level, and then you have the ventilatory disturbance. And the high loop gain is when they have these swings of breathing very heavy and then stopping breathing very heavy. This is hyperventilating and then stopping breathing. And over here is just your muscle activity. And here's your pressures dropping. And you have poor muscle activity. So the muscles aren't going to be working to splint open that collapsible tube. So whether it's a neurologic problem or a muscle problem, doesn't matter, but it has to do with the fact that the muscles aren't working like they should. And then this is what happens, and it's reflected in the EMG there and the EEG, actually. So then if you want to just look at it a different way, we have the impaired anatomy, like everybody has, and then we have the repetitive upper airway obstruction during sleep. This is what's happening, and it's from the top piece here, which is anatomy, and it's contributed by the ineffective upper airway dilator muscles, 36% of the time, low arousal threshold, 37% of the time, and unstable ventilatory control. Now, what's cool, there's something really cool and there's something that's very frustrating. So what's really cool is that if you have impaired anatomy, we have all these different ways we can approach it. We have tools, we have arrows in our quiver. We can treat these different things. Now, if you have the upper airway dilator muscle problem, we have hypoglossal nerve stimulation, upper airway muscle training, and there's certain drugs that can be given as well to stimulate the muscles, which we'll mention later. Now, if you have a low arousal threshold, you can blunt that arousal threshold. So you don't want them to be so reactive and have those arousals, which will interfere and fragment their sleep, which also activates the sympathetic nervous system. So these hypnotics would have to be non-myorelaxant hypnotics, because you don't want to have a negative impact over here on the muscles. Then you have unstable ventilatory control, which is high loop gain. And this is they just have an overreaction to blood gas exchange. So supplemental oxygen has been very good there, supplemental CO2 or acetazolamide. These are different approaches to treating the unstable ventilatory control.
So if a person with UARS is not overreacting to that arousal threshold, isn't that reaction, that brain arousal, saving them? Because if they didn't arouse, they would then soon become apneic fully? Or we're saying that they're actually too sensitive and reacting when they shouldn't? I'm just wondering, if you slightly blunt that, then are they just going to drop in oxygen at one point and then have full collapse? Isn't it kind of saving them that they're waking up?
Yeah, there's a normal zone. There's a normal zone where it's appropriate to have an arousal to protect you from having the apneas and the hypopneas. So if you have one, you can only have one dish here, on the buffet. If you have a low arousal threshold, you're going to be triggering that response in the brain, the cerebral response, and having an arousal very, very quickly with a little minor perturbation. If you blunt it too much, you're not going to have that arousal. And that might lead to having more apneas and more hypopneas.
Okay, but if you have a minor perturbation in the airway and the brain didn't arouse, do we think the perturbation's just going to go away, or is it going to get worse and then you're just sleeping through the beginning part of the problem?
Well, let me explain what I meant when I say perturbation in the airway. When you inhale and exhale, just inhaling and exhaling, you're going to have changes in the pressures in your airway. Okay. So you don't want to have a reaction to every time you have like end expiration, the pressure drops to
Okay.
-10. You don't want to, or -9. You don't want to have somebody at -3 or -4 all of a sudden having an arousal.
Okay, so it's not always a sign that the problem is going to get worse when there's minor perturbations in the airway. It doesn't mean
Right.
it's progressively getting worse. It could
Right.
just be, okay, that makes perfect sense. Thank you.
Normal changes, right? So these are some algorithms in diagnosing and treating the arousal threshold. So we don't really have to get into this, but it says that if you take a fraction of the hypopneas and you make a fraction, the hypopneas over apneas, hypopneas, and reras, Edwards showed that this could give you the information for what the arousal threshold is. And again, the supplemental oxygen is one of the solutions. Isoprene is another one. Our rear is just low arousal thresholds. This might be your upper airway resistance syndrome for sure. Now, you're not going to do this in your office. However, there are companies right now, and there's one that I'm working with, and very, very soon, we're going to have this available to us. I promise you. I can't wait. I've been after them. The Harvard group, I've been after them for 10 years, and they're finally allowing this to come out onto Main Street, which means they're going to partner with the laboratories that do the sleep studies, and they're going to actually have these algorithms built into it. So when you get the sleep study results, you're going to see this is their arousal threshold, this is their loop gain, this is their 𝐃𝐈𝐒𝐂𝐋𝐀, this is their muscle recruitment levels from these algorithms, and it will be right on the PSG or hopefully your HSAT as well. And then you'll be able to discuss this and make rational treatment choices. And how can we make this patient more stable at night and have a better night's sleep? So the ventilatory instability, very simple. There's this breath hold, which is so simple. And you just see, how long can they hold their breath? If 30 seconds breath hold in OSA patients versus 45 seconds in controls. So a short breath hold correlates with a high loop gain. All right. So just they'll have to take a breath, and then they'll start hyperventilating, and then they'll stop breathing. And so short breath hold associates with loop gain problems. And there's a hypersensitive reflex there. This is treated with acetazolamide and O2. And again, I wanted to say, you don't have to do this. This should all be provided for us, and it will be within, I think, 6 months to a year. We're going to have all these numbers, which is so important because it does contribute to the instability of the airway and the continuity of everybody's sleep at night. So if we're looking at the dilator muscle responsiveness, what exactly is the problem here? It could be a neural control, it could be central pattern generator, or it could be on the outside, could be a mechanoreceptor or a chemoreceptor. They could be not functioning properly. They might be not sensitive enough anymore. They may be burned out. Muscle responsiveness, okay, poor sense of the narrowing, which is a feedback from your afferents, and motor control problems as well. So again, that's neurologic. Then there's the muscle effectiveness. What happens is poor neural drive translates to the muscles. You have inefficient muscle fiber orientation. There might be fat. The muscles might have hypertrophied and make them not work so well. There's changes in the muscle fiber type. So there's a lot of problems with this. Estimated from the breathing pattern during sleep. And again, this is going to be, they have data that can be produced from a standard PSG, and it's there. But it's kind of run by Harvard and it's run by Danny Eckert, and there's certain groups that have these algorithms that are used in certain softwares. Completeness is one of them, but this isn't something that's commercially available for all of us yet, but it's soon to be. And for these patients that have poor muscle compensation, they respond really well to the noradrenergic, the reuptake inhibitors disipramine or hypoglossal nerve stimulation. Now, this is a TCA, tricyclic drug here, antidepressant, and disipramine. And really what it is, it's like a serotonin reuptake inhibitor, but it's more for noradrenaline. So it does do a little bit of serotonin as well. So it leaves a little bit more of the noradrenaline or the serotonin in the synapse a little bit longer. It doesn't get uptaken as quickly. And because of that, it stimulates the muscles a little bit more. It's muscle stimulatory. So we do have ways to approach these problems. We just have to be able to identify them, and we have to quantify them. So if they have a low arousal threshold, this goes back to what you asked before, if they have low arousal threshold and elevated loop gain, you might have a combination of O2 therapy and 𝐃𝐈𝐒𝐂𝐋𝐀 for these two things. So the combination of lowering the loop gain and raising the arousal threshold is effective in some patients whose anatomy is not severely compromised. So combining therapies that target multiple traits is really, in select patients, that's a good idea. So again, in 𝐃𝐈𝐒𝐂𝐋𝐀, we have a variety of solutions here. This is a summary slide. And arousal threshold, we have these sedatives like 𝐃𝐈𝐒𝐂𝐋𝐀. And in loop gain, we want to use O2, which blunts the carotid chemoreceptivity and reduces loop gain. CO2 also prevents the lowering of the carbon dioxide ventilatory depression. Cetizolamide prevents excretion of CO2. These are all approaches for treatments of these problems. And as far as muscle responsiveness goes, well, we just had that in the very last slide, so we don't have to review that. And I put this out in a different layout here, just to show you that if the anatomy is impaired, this is the amount of change that we can expect measured in centimeters of water. And we have the mandibular advancement device, upper airway surgery, supine avoidance, weight loss, the use of surfactants. Then we have low arousal threshold. We have non-myorelaxant hypnotics. And these are the changes that we can expect with high loop gain. We can get a 50% decrease in loop gain with supplemental oxygen. Acetazolamide was shown to get a 40% decrease in loop gain, and the impaired dilator muscle function, muscle training, 50% decrease in AHI. So that's good. This speaks to the myos out there. And then there's hypoglossal nerve stimulation, but that's not for every candidate. There's special parameters in order to get that done. So patients with a 𝐃𝐈𝐒𝐂𝐋𝐀 above 0 responded poorly to oral appliance therapy. Why? Because oral appliance therapy can only change it maybe 6. Okay, so if you're over 0, you're going to get to -6. You're still going to be having problems. I just want to add that this also underscores the importance of not doing monotherapy. Somehow along the line, people thought CPAP or oral appliance therapy. Well, I think that we're starting to understand and appreciate that we have to come at this with a bunch of different tools. And we have lots of tools. And expecting monotherapy to work is not necessarily good. It's not a good expectation. So this is a particular study that showed that they had 𝐃𝐈𝐒𝐂𝐋𝐀 above 0, and it wasn't really a good thing to just make oral appliance therapy for them. They need other things added to it. Doesn't mean oral appliance therapy is not helping, but it's not sufficient to solve the problem. And here's another thing another piece that was done by Justin, and it talks about loop gain, predicts response to upper airway surgery in patients with obstructive sleep apnea. And they concluded, and this was very interesting, that high loop gain patients should avoid the surgery because they were not as successful with the surgery outcomes when they had high loop gain. So it's really important to know which patients, the surgeons might want to avoid some of these patients, because this study showed that they were able to predict failure of surgical treatment when there was less stable ventilatory control. Now, if they did the surgery and they also addressed the loop gain, maybe that would be a better approach. So there's flaws with the methodology in every study. If you look for them, you'll find them. So we've entered this new age here of precision medicine, and we got to keep going forward. If you want to find a summary of everything I just discussed, this is in March 2019. I wrote this article on evidence-based treatment for sleep-related breathing disorders. and I summarized. This slide looks familiar. Well, I got permission from Danny Eckert, and I put this slide, and this reviews everything that's in this presentation. And this is an example here where ventilation is below the demand with a deficient anatomy, and that's why the person is having the apneas and hypopneas and collapse in the airway. This is an example of what is going on with the arousal threshold. And you can prevent these interruptions with your sleep at night if you can blunt this. So here's the line, and we would like the ventilation to be down here. This is the ventilatory demand, but as soon as it crosses the arousal threshold, no bueno. That's not good, and that's going to cause a fragmentation of your sleep. So this is a decreased loop gain may prevent ventilatory demand from spiking. So you want to decrease the loop gain as well so that everything becomes a little bit more stable, and then you wouldn't have these arousals here. This is the ventilatory demand, and this is the ventilation, and loop gain can jack it up, and it can cause the arousal, actually. This is a better muscle responsiveness leads to more stable airflow, preventing an arousal. Again, we don't want to have the arousals. We don't want to have the collapses. So we want to have better muscle responsiveness. That's why some of these therapies that I showed in the previous slides will help with that. In the past, this is the then. There was no diagnosis of the cause. This is a really important piece right here. If you don't diagnose the cause, then you either go to CPAP or oral appliance therapy, and either it responds or it's a poor responder. Either it responds or it doesn't respond, incomplete response, or they give it up, and then they go to oral appliance afterwards. So where does this lead us? This is really not a very smart way to approach medicine. On the blue side, which is now, we have a diagnosis of causes. So they have this evidence-based method now. Anatomic factors are the 𝐃𝐈𝐒𝐂𝐋𝐀 factors, and here's all the interventions right here. And we talked about them. If you look at the previous Airway buffet, the previous talk that we had, it goes in great detail about all the different problems. And in the non-anatomic causal factors, we have arousal threshold, loop gain, and muscle response. And that's what we have now. So we can actually target these things, and it's much better if you consider evaluating your patients and diagnosing not just the presence or the severity of OSA, but diagnose the cause. Why is that tube collapsing? Over here in the red, I think we're leaving this whole thing behind. This is the old-fashioned way. I want to call it medicine 2.0, and this is medicine 3.0. Again, this is, you got to hear these things 2 or 3 times. Anatomical deficiency 100% of the time. And then in a third of the time, you're going to have low arousal threshold, high loop gain, or poor muscle recruitment. Again, here are the treatments. This is in that article. It was in Inside Dentistry. This was in the article, and it was also on my previous slide. So what are the causes? That's the next question that you had, Nicole, and you wanted to know, how do you get a low arousal threshold? So I had to actually go to work and study this. Frequent sleep disruptions from poorly controlled asthma or sleep apnea. Okay, that can lead to a low arousal threshold. You can have overreactive control, loop gain. It makes the brain more sensitive to changes in blood gases. Greater airway resistance or increased CO2 and decreased O2 increases respiratory drive. And we know that. Obesity and body composition increases breathing workload and prolonged hypoxemia. Aging increases pharyngeal resistance. Why? You have less muscle tone when you get older. Neurotransmitter changes. Hypoxia acts as neurocognitive depressant, and arousal dysregulation leads to arousal dysregulation. And anatomical structures and muscle responsiveness interact with arousal threshold. And there's genetic and neurobiological factors as well, and the reticular activating system. So the summary on arousal threshold is low arousal threshold is a result of a combination of sleep fragmentation, ventilatory control instability, respiratory challenges, body composition, age, and neurobiological factors. So that's the answer to the question that you brought up last week. That's what leads to arousal threshold. So some of it's neuro, and some of it's not. Most of it's neuro. Okay, let's get on to loop gain. What are the causes of non-anatomic, this part of this non-anatomic triad? So if you have increased sensitivity of the respiratory control system, small changes in the gas exchange lead to disproportionately large ventilatory responses. So why does that happen? So keep in mind that loop gain is an engineering term. It's not a sleep apnea term. And there's two pieces to this. There's the controller, and then there's the plant. And stay with me here because it will make sense. The controller is your brain or the sensors. They make the decision. That's the thermostat. It could be in your brainstem or it could be where the sensors are, but they are not affecting the lungs necessarily. The lungs are what we call the plant. Okay, so high controller gain, the controller refers to the brainstem, increase in the chemoreceptors or decrease in the pressure, the baroreceptors, having a heightened responsiveness, it should be. So the baroreceptors sensitivity can be increased with slow breathing exercises. So breathing exercises can actually help, and it will make the baroreceptors more receptive. Okay, so intermittent hypoxia from OSA can sensitize the carotid body and increase controller gain. Again, controllers are in the brainstem and at the receptor level. Now, the plant gain, now we're talking about the lungs. If the lungs are very efficient at gas exchange, a small increase in ventilation causes a larger than normal drop in CO2 and a rise in the oxygen, which leaves the system prone to overcorrection. And that's what's going on with loop gain. So the lower lung volume, okay, from obesity, decreased lung volume, they might have had surgery or problem, it leads to high plant gain and makes ventilatory response more extreme. So they're not having good gas exchange, so it overreacts. Aging also affects the lung structure and decreases the loop gain. Circulatory delay, where there's a delay between change in ventilation and chemoreceptor registering this change, like in heart failure, the feedback loop becomes unstable and leads to high loop gain. Also, there are neuroplastic changes from repeated hypoxia in the system sensitivity and leads to high loop gain. Okay, now there's one more. First, let's summarize this. So high loop gain, which is unstable control system that oscillates with minor disturbances causing a system to overreact, but it overreacts both ways, both directions. The control system composed of the controller, which is the brainstem and the receptors, and then the plant, which is the lungs. The system swings between hyperventilation and hypo, and even there are central apneas that come into play. Now, the last one is muscle recruitment deficiency. So intermittent hypoxia leads to a decrease in muscle responsiveness or recruitment. High loop gain exacerbates reduced activity of the upper airway dilator muscles. Aging leads to sarcopenia. The muscle fibers decrease in size and number, and the upper airway muscles composition can change from fast twitch fibers, and they can be altered into slow twitch fibers. Also, changes in the muscle fiber orientation and fibrosis from nightly upper airway resistance. So these repetitive episodes can pay a toll on the muscle composition as well. Then there's also an altered neuron function. So there's poor neural responsiveness. So poor functional muscle response this is a summary, is a result of muscle fibers have been altered. They've altered fiber type composition, cytoskeletal protein abnormalities, neuromuscular injuries, impaired neural control, which can be blood flow to the nerves. These are both adaptive compensations and pathological responses to a chronic intermittent obstruction. And then there's vibrational trauma as well in OSA. Now, this slide, don't get upset. I'm not going to go through all of this, but this is a general slide that is really not so scary, but it shows that these are your sensors. You have these afferent sensors, and afferents, remember, go up towards the cortex. So you have them from cranial nerve 7, 9, and 10. You have the glossopharyngeal is 9, and the vagus and the facial nerve, and they usually go up tractus solitarius to the solitary nucleus, and they go all the way up to the cerebral cortical arousal. This causes the arousals. And look what happens. You get these sympathetic neural response. And you also get endocrine, thyroid, adrenals, you get all this stuff. So this happens, and it's pretty regular. And this is the way you keep your homeostasis. So it's not anything strange. Sometimes, though, there can be a line drawn here, and nothing goes up to the cerebral cortical areas, and there is no arousal. And at the solitary nucleus, these afferents can be shunted over to the amygdala. This is the limbic system pathway. This goes to the hypothalamus. This can also activate the sympathetic nervous system. So this is what's called a subcortical arousal. And you can get the adrenal glands to release adrenaline and cortisol. So you don't need to necessarily have an arousal. Now, this is really, Nicole, this is what we're talking about when we're talking about these UARS patients. They could have absolutely no cortical arousals, but they have this activated sympathetic nervous system going on. So there might be some reason neurologically why they're more prone to going through this limbic pathway than going up and having the cortical arousal, and that's to be learned. Now, there are other issues. I did some research, and I wanted to put all these other issues, which are non-airway issues, okay, that influence the upper airway. So let's look at that. And there's about 3 or 4 slides, and then we'll be wrapping it up. So GERD and LPR, which is laryngopharyngeal reflux, it's really the same thing. GERD is when the acid and stomach contents get into the lower esophagus, and they go past the lower esophageal sphincter. And the LPR is when a little bit of acid gets into the esophagus and goes all the way across and gets across the upper esophageal sphincter muscle. There's 2 sphincter muscles. And when it does that, the LPR can actually get into your throat, and you can get hoarseness, and your vocalization can sound a little raspy. And that's LPR. Okay, it's much less volume of acid, but because you don't feel it, all right? Whereas when you have the GERD, you're feeling a lot of acid in the esophagus. You can have both also. So same pathophysiology, so it's no different. And the gastroenterologist really should start, anybody that presents with these things, they should look at the airway, because it's the negative pressures in the lower airway that initiate this problem, always. The insufficiency in the lower esophageal sphincter muscle is not something they're born with. It's something that's developed. And if you think of the uvula and what that looks like in a patient that's had obstructive sleep apnea for 20 or 30 years, it's long, edematous, and fat, inflamed. And what do you think happens to the little muscle flaps in the lower esophageal sphincter? They become dysfunctional. So yes, the gastroenterologist is right, but they're not treating the cause. They should look at the cause. Now, if you have tumors or masses pressing on the trachea or the bronchi, what do you think happens? That decreases the lumen, all right? When you have a little bar straw versus a garden hose, the air has to go faster, and we know the pressure drops. How about fluid shifts, rostral fluid flow from cardiac, renal failure, venous insufficiency, and pregnancy? So this changes also the diameter of the airway. Lung volume can be compromised. What happens if you have decreased lung volume? You have decrease in traction. And it's the pulling or the traction that actually helps to maintain the airway in many cases, decreases the collapsibility. Some examples of this might be COPD, asthma, chronic bronchitis, or cystic fibrosis. Now, there's neurological problems as well. Stroke and head injuries can reduce upper airway muscle tone. So it's another thing that contributes to the muscle difficulties. Neuromuscular conditions such as ALS, Duchenne's, Guillain-Barré syndrome, myasthenia gravis, and spinal muscular atrophy can contribute to the problems of the airway collapsibility. Then there's vitamin D, which you mentioned last time. Increase upper airway resistance. It increases it. So if you have a deficiency, you have more resistance. It worsens your lung function. It increases your airway smooth muscle mass, which decreases the airway size. It causes inflammation. It induces inflammatory cytokine expression, the deficiency. So it may lead to airway hyperresponsiveness, autonomic dysfunction. Then you got this renin-angiotensin-aldosterone system, which leads to increased renin secretion, which increases your sympathetic nervous system. So vitamin D is a big player, and there are other people that can speak on that for hours and days. Aging is a factor. Aging decreases the muscle tone. We all know that. Low iron reduces the oxygen carrying capacity in the blood and has neural effects as well. Hormones, testosterone increases collapsibility in sleep. Estrogen and progesterone decrease the collapsibility. So if you're a woman and you're going through some premenopausal or menopausal or postmenopausal problems with your sleep, I mean, there's a lot of factors, of course, but there are bioidentical hormones now, estrogen patches, transdermal patches, which have been shown to be very, very helpful for the collapsibility of the airway. And Dale Bredesen actually talks about taking some of these bioidentical transdermal patches of hormones for women for the prevention of MCI, which is cognitive impairment, mild cognitive impairment, and dementia. So it's very good at preventing neurological problems. Well, anytime you're going to have a lot of fragmentation in your sleep, you're going to have less slow wave sleep, and less garbage is going to be taken out. So there's an increase in the tau proteins, and the beta amyloid plaques will get enhanced. Diabetes. Okay, what happens in diabetes? So diabetes is interesting because it really hits on a lot of different areas. You get damaged nerves, neuropathies to the upper airway muscles. Why? Because of the circulation mostly. Chemoreceptor dysfunction. It can affect the carotid body and gas sensor. Increase in oxidative stress causes tissue damage in the upper airway. Then there's the glycemic control and OSA. So these things are bidirectional and they affect each other. So if they have diabetes, that's going to be another problem. And you know what? Metformin can treat this. All these things are treatable. So the reason we're doing this is say, hey, what about all these other things? And they can help. So here's one that gets a lot of news lately, the circadian rhythm dysregulation. And it turns out that it's bidirectional. Circadian rhythm disorders occur when the body's natural sleep-wake cycle is disrupted. It could be genetics, it could be your lifestyle, it could be environmental influences. And there's endogenous circadian rhythms. They regulate upper airway, as it turns out, the muscle tone and inflammatory responses that maintain airway patency. So there's rhythms. All the chemistry in your body has certain rhythms. And once you disrupt the circadian rhythms, you disrupt muscle tone, you disrupt inflammatory responses. Everything gets disrupted. Dilator muscles exhibit reduced activity during sleep, and they're influenced by circadian misalignment. So if you're jet lagged, you're going to probably have circadian misalignment. And there's ways to treat that. Disrupted circadian rhythm can affect ventilatory control, stability, loop gain, muscle responsiveness, and sympathetic neural activity. So jet lag can be a big deal at disrupting this, and night workers, shift workers, good luck with that. So in the summary, this is called chronobiology. Intermittent hypoxia and arousals and obstructive sleep apnea and UARS lead to circadian clock disruption. So it goes the other way. This shows the bidirectionality. So they dysregulate the genes, the clock genes, which alter your respiratory function, your muscle contractility, and your airway and resistance and collapsibility. And finally, we get to this thing called trigeminal cardiac reflex, TCR. So this is really an interesting one, and it was new to me last year, and I wanted to know, why is this so important? Because I heard some people talk about it. And we're going to dig in to this one just briefly. Activation of this trigeminal cardiac reflex occurs when sensory branches of the trigeminal nerve are stimulated. So chewing or jaw extension, that's going to be your afferents. That's going to send signals through the Geissian ganglion to the sensory nucleus of the trigeminal nerve in the brainstem. Then it goes to the reticular formation in the brainstem. There's efferents, okay? This goes to the motor nucleus of the vagus nerve, part of the brainstem's parasympathetic system, and that leads to a vagal dominance. A vagal dominance creates parasympathetic outflow, and it inhibits the sympathetic and leads to bradycardia, hypotension, and apnea. So this is interesting because TCR is a protective oxygen conserving ancient brainstem reflex. So this is a diving reflex that you heard about, and maybe 2 million years ago, animals needed to dive and were in hypoxic environments. It played a role. The question is, what does it do today? What does it do for humans today? Is it just some archaic neurological reflex? And that's what it is thought to be. There's a reduction in neural output to the dilator muscle and leads to atonia. So it gets you adapted more or less to a hypoxic environment. So TCR is associated with a release of nitric oxide, and opens the blood vessels, especially in the periphery, and decreases the blood pressure. So you get hypotension. Decreased blood flow to respiratory muscles leads to atonia. So this reflex that you have can actually cause apneas as well. Pushing the jaw forward or moving or clenching the jaw can actually help cause the upper airway collapse. So there's increased resistance and collapse of the airway. So there's much more to this. I mean, this evidently could be a full seminar in itself, the TCR reflex. It's interesting. Now, we're just going to wrap it up and put everything in perspective. What we're studying today has to do with this upper left. It's our airway knowledge and our sleep knowledge. That's really where I've been concentrating. But really, there's much more to this picture. There's much, much more. So this is a little graph I made for sleep and airway landscape today. We have immunology, which is another factor that plays into this. So we have knowledge basis of comorbid non-communicable diseases. We have all different interventions, which we mentioned. There's a lot of publications on sleep and airway. We have growth and development issues, which play into this from different age groups if they're growing still. And the airway also there's certain phenomics, there's genes and gene expression, epigenomics, allergies. All this stuff is so interesting how it plays into this. What turns on the genes and off the genes, the transcriptomics, proteins and the proteomics and the metagenomics and the metabolics and the pharmacogenomics, all the medications that we can make available today. So these keep coming out and they're very, very interesting. And basically it's our bodies want to be in homeostasis. Our bodies want to survive. We don't want to be unhealthy and have all our systems break down, and we want to breathe better. And unfortunately, our airways are compromised in our modern world. And so I'm glad that we had the opportunity to sit back and talk a little bit about this and consider the non-anatomical pieces of this. And there's more, so leave room for dessert. I'm giving a course September 18th and 19th in Northport, and it's an implementation course. It's for the full staff. It's not just for the docs, because if there are any doctors watching this right now, you really can't institute this in your office by yourself. You need somebody to run the insurance and patient management, and you need your assistants to collect the data. If you have to collect all the data and make sense of it, I think you're going to not have time to do that in the current day. So you need your whole staff to be involved. I have my information, how to get in touch with me. And if you have any questions, just email me. That's the best. This is my cell number that I put on the screen here. So feel free anytime to get in touch. And Nicole, I just want to say thank you very much again for making this forum available to me and for all of your listeners.
Wow. Thank you so much, Dr. Lamberg. That was phenomenal. That was so great. And I'm so glad we recorded that, because I will be watching that at least 3 more times. That covered so much territory. I'm kind of overwhelmed in a good way. I feel like a full sponge right now of information. I am just thinking, wow, I have all these questions, and we're not going to have time to do questions today, but
Okay.
I'm just really thinking and realizing this is highlighting the fact, of course, monotherapy is never enough and never acceptable. But that buffet, there are so many different factors. And I think a lot of people don't pay attention to all those different factors. One of us cannot cure this problem in any patient. And just knowing those non-anatomical factors and how prevalent they are in our sleep disordered breathing patients makes you realize that just treating the anatomical is not going to resolve completely the issue in most cases. And so we need to be aware of those other factors, find ways to diagnose those other components, and address them. And it's referring out to sleep doctors and other people to help with these issues. And I'm just wondering, because we're short on time, I'm almost thinking if people who are watching this can write in the comments questions they have, and perhaps we can re-meet and do a question and answer just about this topic. One of my questions is, how do people diagnose these non-anatomical factors? And I know you talked about that's going to be something that's going to be coming soon. And how is that going to be? Because that is so important. Plus, I have a few other questions and thoughts as well. And one thought is also exercise. My dad, who's a runner, who has sleep apnea, the sleep doctor told him, if you weren't a runner and exercising, you would probably be in a lot worse condition now. And to me, that's hitting on the loop gain factor and the lungs be able to process the oxygen better. So there's so many different aspects to this. Now people have breathing programs during the day, and oh my gosh, it's so overwhelming. That was a meaty buffet. Let's say that was not a vegan buffet. That was a carnivorous feast. I mean, that was so meaty. I just love that. That was so great.
We'll get together and answer the questions. Yeah.
Wow. You know so much. Thank you so much for putting that together and all of your time. It's just so greatly appreciated. Thank you so much, Dr. Lamberg.
You're welcome, Nicole. Thank you. Have a great day.
You too. Take care. Thank you again.
Good luck, everybody.
Thank you. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.